Hi, welcome to What's Happening at Tri-City Medical Center. I'm John Bonosoro, and I'll be your host for this new series made in collaboration with KOCT, North County's channel, and Tri-City Medical Center. Our goal is to keep you informed about health issues, events, and services at your local hospital and to provide you with information for a healthy lifestyle. June is Men's Health Month, and we have the perfect guest to discuss that topic. Dr. Jason Phillips is a board-certified urologist specializing in men's and women's urologic health. Dedicated to providing patients superior care, he has a special interest in treating BPH, urologic cancers, kidney stones, overactive bladder, incontinence, bladder prolapse, and erectile dysfunction. Dr. Phillips works at North Coast Urology in Oceanside, and he's a staff physician and surgeon at Tri-City Medical Center. Doctor, what does a urologist do? That was a pretty complete list that I went through. Fill that in a little bit for us.
Yeah, thank you, John. So a urologist is a surgical subspecialist that focuses on the urinary system in women and the genito and urinary system in men, comprising the kidneys, the ureters, the bladder, prostate, as well as the penis and the testicles.
We hear a lot when we talk about men's health about the importance for checkups as opposed to waiting for symptoms. Can you tell us why that's so important?
Absolutely. For men's health, as men get older, we think of the cardiovascular system, and we think of all the other systems such as musculoskeletal and arthritis. But if you're looking at men's health and for men's health awareness, the urologist plays a very important role because we are involved with testosterone, erectile dysfunction, prostate issues, whether that's prostatitis, BPH, which stands for benign prostatic hyperplasia, or in just colloquial terms, a big prostate, which the end result is difficulty with urination.
Some of these can happen at any time, but many of them are very age-related, correct?
Absolutely. If you look at men as they get older, probably 50% of men who are 50 years old have urinary difficulties. If you look at men kind of across the entire nation, there's at least 30 million men with erectile dysfunction, and low testosterone becomes much more prevalent as men get older. And men are much less likely to go to their doctor than women are because they don't have the obstetrician or kind of that lifelong care. So as men get older, it becomes much more important to go to the urologist and your primary care physician. For example, I'll see men that have erectile dysfunction, and that's a precursor for cardiovascular disease. And if we find that, we'll often refer them over to see a cardiologist and sometimes catch heart disease earlier.
We talked about early tests. What frequency do you recommend?
Absolutely. Specific to urology, the PSA level has been really controversial after the U.S. Preventive Task Force came in and said they don't recommend screening. Our organization says we do recommend screening. For most men, typically around the age 50 to 55, I recommend a PSA level. Unless they have a first-degree relative or a really strong family history of prostate cancer, then maybe around 45. And then that frequency should be every year to every 2 years. And a digital rectal exam should also be performed. And that's for prostate health, prostate cancer screening.
What do we know about the causes of BPH?
Sure. BPH, as I mentioned, is benign prostatic hyperplasia, growing prostate. And it's like a donut. And as the donut grows bigger on the outside, well, we'll notice it on the exam, but the inside of the donut, or the donut hole, can become tighter and tighter. And then as that becomes, I guess, more difficult to urinate, that'll put pressure on the bladder and cause such symptoms as urgency, frequency, and difficulty with urination. We haven't really tied a definitive kind of environmental factor to it. There is a genetic predisposition, and probably the #1 risk factor is just getting older.
Okay. Which is something we all want to have because the alternative's not too pleasant.
Absolutely.
So what are the treatments?
So for the treatments for BPH, always start with medications and lifestyle changes. If that's not enough, then we have different surgical treatments. And the surgical treatments, the least invasive that I do in the office is something called the Urolift, which will manually push open the prostate to open up the donut hole so men can urinate better, and then the pressure's off the bladder. And then for other men, other treatments are required, such as a transurethral resection of the prostate. That's under anesthesia, where a camera is placed inside, and some of the tissue is actually removed, so that donut hole is opened up. Think of like an orange, where you take the fruit out of the inside of the orange and you're left with the peel. Well, that cavity is much bigger, the resistance is much less. You can urinate with a stronger stream. I also do that with a laser, a green light laser, but also under anesthesia. And for some men who have very, very large prostates, I actually require an open surgery or a robotic simple prostatectomy. That's probably the most invasive, but every man needs a different treatment that's tailored towards them. And typically I always start with medications. Then if their prostate is amenable, a minimally invasive treatment such as the Urolift, and then proceed down the path. You don't burn any bridges with either the medications or the Urolift, and then once you get to either a TURP or a green light laser or a simple prostatectomy, those men need usually significant help.
You talked about lifestyle changes. Can you give us a couple?
Sure. Think of truck drivers. They don't drink a lot of water. They don't go pee very often. They're going to be holding their urine, and they're training their bladder to be dysfunctional. I recommend, a man as he gets older to try and urinate, consistently, about every 2 to 4 hours, and really try and empty. And as it becomes harder to urinate and harder to empty the bladder, I recommend about, a few deep breaths when you're going to the restroom, so you can really empty out the bladder. Don't hold it too long, otherwise you will get some dysfunction with the bladder.
And I want to stress, we're talking about the benign version of this.
Absolutely.
Up till this point.
Absolutely.
With your treatment options. Another major issue, I think you mentioned 30 million men in America, is erectile dysfunction. Certainly a major topic in the news, everything from medical journals to pop culture. So what do we know about the causes and treatments for that?
Sure, absolutely. Erectile dysfunction is very prevalent, and I'll tell you, many men are embarrassed of erectile dysfunction or have difficulty going to their doctor about it, but it's very common. You mentioned 30 million men, very, very common. So with erectile dysfunction, typically it's a narrowing of the arteries that go to the, not always, but typically narrowing of the arteries going to the penis. And that causes the blood, to mess and have an erection. So that's why it's a precursor for heart disease, because those arteries are even smaller. As for treatments, I typically will list about 5 that I can offer men. And I always start with medications. Think of the Viagras or the Cialises. Often that's all men will need. But if that's not enough, there can be a vacuum erection device. Think of negative suction to allow an erection, and usually a tight constriction ring is placed at the base of the penis. And then we get into little pills or injections, and you can put a pill in the actual urethra to cause an erection. And if that doesn't work, then, as tough as it sounds, you can inject a medication directly into the penis, and that often gives an erection. And if nothing works and the erection is still something that's desired, I can put a penile implant in. And these penile prostheses work every time. Men have a very high satisfaction rate with them. And I've actually been very impressed with the results and have gotten very good feedback about this.
Okay, lots of options, more than probably most men know about.
Absolutely.
And finally, we have about a minute left. What about the causes and treatment of low testosterone?
Sure. Low testosterone happens as men age. There may actually be a protective effect. You decrease the testosterone, you might, as men age, you may very well be protecting men against doing more activities, more, aggressive activities. However, people are living longer, people are more active, and so the low testosterone can manifest as weight gain, low libido, erectile dysfunction, depression, and that can play a significant role in a man's life. Treatments for that, well, the workup for that is to get lab tests and then to be able to see their doctor. And then treatments for testosterone is testosterone replacement therapy. And those can be gels or creams, or they can be shots. And I actually have little pellets that I can put into the muscle right in the gluteus, right in the fat there, that can last for about 6 months. And so men can have an increase in energy, weight gain, weight loss, muscle gain, as well as erections and libido.
Wow, that's a lot of information presented very effectively. Thank you.
Thank you.
And Dr. Phillips, remember, is an expert in this. If there's something you heard that resonates with you, you need to see your doctor.
watching online videos like this one.
Brushing for 2 minutes now can save your child from severe tooth pain later. 2 minutes twice a day. They have the time.
Welcome to What's Happening at Tri-City Medical Center. With us is Dr. Jason Phillips, a board-certified urologist and chair of urology at Tri-City Hospital, specializing in men's and women's urologic health. June is Men's Health Month, and we will be receiving some great insight from Dr. Phillips, who is one of the many skilled surgeons who operate at Tri-City Medical Center. Dr. Phillips, let's talk about BPH. Let's start with what it is and how common it is.
Well, thanks, John. Thanks for having me. So BPH stands for benign prostatic hyperplasia, which more or less is a big prostate. And as prostates get bigger, as men get older, it can put pressure on the bladder and cause difficulties with urination. Typically, this manifests as either obstructive or irritative urinary symptoms. Obstructive urinary symptoms are the classic weak stream, hard to start, interrupted stream, and the feeling like you have to go even after you've just went to the restroom. Irritative symptoms would be getting up at night, feeling like you have to go all day, going very often, urgency, and frequency.
When someone comes in with those symptoms, what is your workup?
Absolutely. The very first thing that we try and rule out is there any component of prostate cancer? So men coming in with difficulties with urination get a PSA level, a digital rectal exam. I measure to see how much urine is left in the bladder, and I actually measure the prostate as well with an ultrasound. Men who then are trialed on a medication, and then if they don't have successful resolution of their symptoms, I often will put a camera into the bladder to look at the prostate from the inside. Think of a donut. The ultrasound looks at the outside of the prostate, the camera looks at the inside. How tight is the prostate, and how much pressure is it putting back on the bladder when it's obstructing the urinary flow? I should get all that information after all those tests.
And I just realized that with my first question, we may have sent a bad signal because we don't really want people waiting for symptoms to come in, do we?
Absolutely. You know, I often see men as they've kind of progressed in their bladder dysfunction, and they might be in urinary retention. Well, that damages the bladder. If I can help men earlier, either with medications or a minimally invasive procedure, it can cause their bladder health to be better longer.
Is it safe to say that waiting is never a good thing with these types of symptoms?
Well, sometimes the bladder symptoms can get better. Think of a prostatitis, some inflammation of the prostate, or an infection. But if men get infections or they're having prostate issues, they should definitely come see me or another urologist.
Okay. And what treatments options are there?
Treatment options for BPH are either medications, procedures, or surgery. I always start with medications. Think of Flomax. It's an alpha blocker that relaxes the prostate. If you relax the smooth muscle around the prostate, the flow will improve. And then there's alpha reductase inhibitors. Think of medications called finasteride, dutasteride, Proscar, Avodart. These will actually physically shrink the prostate, but they can have sexual side effects, which aren't good for younger men, but might be fine for older men. And then we move on to the minimally invasive procedures, such as the Urolift. It's the only one of its kind to actually physically open up the prostate without destroying tissue. And then we have other procedures that can be done in the office or operating room that are used to kind of destroy the tissue, to be able to open up, remove the tissue, so it opens up that fossa, so the inside of the donut hole opens up, men can pee with a stronger stream. Some examples of that: transurethral resection of the prostate, TURP. You can use a button for plasma vaporization of the prostate, green light laser, microwave. And then there's more invasive treatments, such as a simple prostatectomy that I will do either open or with a robot to actually do a surgery to kind of take out the inside of the prostate. Think of taking the orange and leaving the orange peel. Well, that's going to be a nice open prostatic fossa to improve urinary flow.
Now, Urolift is relatively new?
It is relatively new.
And you've adopted that. You are an early adopter of that. What are the advantages?
Sure, absolutely. So with pretty much all treatments for prostate cancer, there can be an effect on ejaculation. We call it retrograde ejaculation, and more or less it's either relaxing the smooth muscle of the urethra or that kind of opening. Think of the orange again. You're taking out the meat of the orange and the fruit of the orange, so you have the orange peel. Well, that's where the ejaculate kind of stays and it can't come out the penis. The UroLift is actually the only treatment where you can open up the prostate, get relief, but retain the ability to ejaculate. The other thing that the UroLift is really good for is that I can do it on men that are on blood thinners, because I'm not destroying tissue, and I can do it on men younger or older without the sexual issues. And then for men who are on medications, it takes away those side effects of the medications while retaining improved urinary flow. And if you're looking at the improvement based off of the symptom scores that we use with the American Urological Association Symptom Index, you get about a 10-point increase with the UroLift, where it's much smaller with medications.
Wow, that sounds like a great new benefit. And how long has it been around?
It's been around for about 4 years.
Okay, so I have a good track record on it, so those statistics are very meaningful.
I have a good track record with it, and I'm probably the leading implanter in North County.
What else do we need to know about BPH?
Sure. When I see men with BPH, not every treatment is right for every man. And I would say my philosophy is to try and get the right treatment at the right time for the right man. Take, for example, the UroLift. It's not the right treatment for every man. It's a good treatment for many men. If men have been on medications for quite some time, or even a short period of time, I offer them the UroLift if their prostate is the right size and the right shape. If it's too big, maybe a simple prostatectomy is what that man really needs. If the symptoms are mild, maybe medications are what they need. But with the UroLift, you're not burning any bridges. You can always move on to further treatments. And if you get sufficient symptom relief, well then their quality of life has improved significantly.
When you say not burning bridges, are you implying that means that what you've done doesn't preclude the use of one of the other treatments?
Absolutely. Doesn't preclude the use of any other treatments, doesn't preclude prostate cancer screening, MRIs, or any other treatments that might need to be undergone for the pelvis.
Okay, so there could be a series of options, not just one option and you're done.
Absolutely.
Okay, very good. I think we have very effectively covered BPH, and thanks to Dr. Phillips for filling us in on the important subject of BPH.
You're doing great. We're gonna try this again, okay?
Okay.
Wheels, pedals, handlebar, brakes. Sit up straight, keep your weight in the center, keep your eyes on the road, hands on the grips, butt in the seat. If we feel ourselves falling, what do?
Just keep pedaling.
Good girl. Now remember, it's all about balance and steering. Steer with your hands, steer with your body. Steer into the corners and you stay out of trouble. And the bell's your buddy, so go ahead and ding that. All right, you ready? Here we go. Pedal, honey, pedal. There you go, you're a bike rider.
Most parenting is hard to do in just 2 minutes. But 2 minutes twice a day making sure they brush is easier, and it could help save them from a lifetime of tooth pain.
Welcome to What's Happening at Tri-City Medical Center. June is Men's Health Month, and with us is Dr. Jason Phillips, who is a board-certified urologist, physician, surgeon, and chair of urology at Tri-City Medical Center. He specializes in men's and women's urologic health. Doctor, we need to get to the subject of prostate cancer. And I think a lot of men look at it that way. We have to need, we don't get to it until we need to get to it, and that's probably unfortunate. So introduce the subject to us.
Sure, absolutely. Prostate cancer is very prevalent. Approximately 230,000 cases of prostate cancer are diagnosed every year. Second leading cause of cancer death in men, about 23,000 cases or deaths a year from prostate cancer. Approximately 1 in 7 men will be diagnosed with prostate cancer in their lifetime. I mean, this is something that we need to continue to bring to the forefront of men's health. Screening for prostate cancer, as recommended from the American Urological Association, should occur approximately around 50 or 55 years of age and should consist of a digital rectal exam and a PSA level. Now, the PSA level has been controversial. And the U.S. Preventative Task Force at one point said that, well, maybe we shouldn't check PSA levels. And what happened is that the PSA detection rate and screening started to decrease. And what I'm seeing at this point is that the detection of higher risk prostate cancers is going up because we're detecting prostate cancer a little bit later. if you take the historical perspective prior to PSA level, well, more men were diagnosed with late-stage prostate cancer. When PSA was initially found and brought to mainstream, prostate cancers were diagnosed earlier. And once they were diagnosed earlier, they were able to be treated earlier. And that in itself created a little bit of controversy, because if you diagnose low-risk prostate cancer, will that cause, I guess, morbidity or mortality? Sometimes yes, sometimes no. And our goal over the next 5 years, 10 years as a urological community is to be able to delineate and differentiate high-risk prostate cancer versus low-risk prostate cancer and be able to treat men accordingly.
What types of solutions are you looking to in order to be able to do that?
Absolutely, and a lot of these tests are in their infancy. But let's take a man who might have an elevated PSA level, no family history, and we're worried about prostate cancer. Well, at that point, I can offer a few different tests, such as a prostate MRI, the 4K test, which is a blood test, or the Select MDX test, which is a urine test, to try and risk stratify with negative and positive predictive values the risk of high-risk prostate cancer. If I'm worried about high-risk prostate cancer, then I definitely recommend a biopsy.
Do you expect that this is something that's going to be resolved soon? I mean, you mentioned 5 years. That sounds like a long time. Are you gathering information along the way?
Sure, it's a continuously changing, I guess, environment, and this area is in its infancy, but it's continuing to develop, and algorithms from UC San Francisco and private companies, even locally here in Southern California, are trying to develop ways to be able to get a better test than the PSA level.
However, we're not at the point where we're not going to do PSA.
Correct. At this point, the American Urological Association recommends PSA and digital rectal exam as the cornerstone for being able to detect prostate cancer. And so when a man comes into my office, whether they've got lower urinary tract symptoms or an elevated PSA, I always ask a few different questions, because men's health is not always evaluated at the primary care level and is not always talked about in the community. So when a man comes to me, I always check their urinary symptoms, check their prostate. Is there a prostate nodule that's concerning for prostate cancer? Is it a large prostate? Are there urinary symptoms that are disruptive to life? I also ask about erectile dysfunction. And then the combination of the PSA level and a digital rectal exam will help determine the risk for me if the patient needs to have further testing. And I also ask about family history. It's known that men with first-degree relative that has prostate cancer, especially at a young age, might have a genetic predilection for having prostate cancer. And so if there's risk factors that are present, then we'd move on to a biopsy. And the biopsy I do with an ultrasound, and the ultrasound allows me to place lidocaine, or same thing you get for having your teeth done, to help numb up the prostate, and then I take a needle to take biopsy cores to be able to determine if there's prostate cancer. The pathology that comes back, or I should say, the tissue that comes back, whether it's prostate cancer or not, will then help determine what the next steps are. And traditionally, if there's prostate cancer, we seek treatment. If there's not prostate cancer, we continue with being able to screen patients. But more recently, over the last few years, there's actually been some molecular tests that are trying to look at this very question as well, trying to decide high risk or low risk. For example, I'll give you a couple names: Oncotype DX, Decipher, Prolaris, Confirm MDX. So if a man has a negative biopsy, I'll ask that biopsy to be evaluated by Confirm MDX to see if there's DNA methylation, fancy term, but to see if there's more risk that there could be prostate cancer nearby. If it is prostate cancer present, they get stratified into high risk, intermediate, low, or very low. And these molecular tests will help confirm whether it's really truly low risk, or if it's an intermediate risk, is it higher or lower? And that can help determine some of the treatment options for the patient and help determine the path.
Well, we've got a couple of minutes left. Let's get into those treatment options. I assume, well, let's start with the low order.
Sure, absolutely. Men with low risk or low risk prostate cancer, I often recommend active surveillance. And active surveillance isn't just watching it, it's actively watching what the changes are in the prostate. And that will typically involve a PSA level and a rectal exam to be able to feel the prostate, anywhere between every 3 and 6 months, a confirmatory biopsy at a year, and even an MRI to be able to see if there's any new lesions. Men with intermediate or high risk cancer aren't good candidates for that. So men who have localized prostate cancer, where I think it's only in the prostate and not in the bones or outside of the prostate, would benefit from a definitive treatment for the prostate cancer. There are many ways that you could read on the internet to do this. Probably the two that have the best 5-year and 10-year survival rates would be radical prostatectomy, which I do with a robot, the Da Vinci robot at Tri-City Medical Center, so a robotic radical prostatectomy, or external beam radiation therapy, which would be done by a radiation oncologist. And there are a number of those here in North County.
What should a man expect in terms of the progression of prostate cancer? Or is it literally all over the map? Is it extremely individualized?
It's extremely individualized. And we talk about localized prostate cancer. Well, if you have localized prostate cancer, you have the chance for cure and to be able to remove the prostate or to be able to, I guess, get rid of those cancer cells. If the prostate cancer is spread outside of the prostate and has gone into the bones or into the lymph nodes, then we start talking about systemic treatments that can't cure prostate cancer, but can treat prostate cancer, maintain a nice quality of life, and extend life. And the mainstay of that is androgen deprivation therapy. And actually the man, or the two men that found androgen deprivation therapy with Lupron, I think right about 1980, they won the Nobel Prize, one of 2 urologists to do that. But with that, we're actually kind of in the, I would call it even the golden age of treatments for metastatic prostate cancer, where if the androgen deprivation therapy, taking the testosterone out of the body, isn't working anymore to suppress the prostate cancer, we have other treatments that can work on the adrenal glands, and we actually have immunotherapy, which is the very first immunotherapy that was developed against cancer in the human body, called Provenge, which can attack cancer cells and prolong life. And all this can be done before we think of chemotherapy.
Well, Doctor, thanks for this great information on this important issue. And as a reminder to everybody out there, it starts with the diagnosis, which means you have to have that checkup. You've been watching KOCT's new program, What's Happening at Tri-City Medical Center. I'm your host, John Bonosoro. This new series will keep you informed about health issues, events, and services at Tri-City Medical Center and provide you with information for a healthy lifestyle. Watch for more segments in the new series, What's Happening at Tri-City Medical Center.